Great. Thank you very much. It is a true pleasure to be here to talk to this group about combination therapy for hepatitis B. I want to point out one thing on my introductory slide is that I'm perhaps one of the few fellows of both the AASLD and Infectious Disease Society of America. And what I would point out is that does make a difference in how we think about the approach to viral hepatitis. It did in hepatitis C, and I believe it will with hepatitis B as well. So what I'd like to do, I realized actually last night that I had 17 minutes to cover this topic. I had to cut my 25-minute talk down a bit. But I'd like to go through just some general concepts. My intent is not to cover every drug in development, but to think about some issues related to sequencing of therapy and to think about some of the areas that we need to address in terms of combination regimens. I also wanted to start by thinking about just where we have been. We actually haven't had a new therapeutic entity for hepatitis B since 1998, and that was the polymerase inhibitor lamivudine, which of course is a long period of time without antiviral therapy, and we haven't made advances. So I think in general we have a long way to go, but the momentum we've had in the last 5 years with respect to therapeutics is really impressive. I also want to touch on the issue of the treatment is recommended for only people who have active hepatitis. But as we think about how some modalities may work, particularly antivirals, they may actually work better in younger people with high levels of viremia, primarily with S antigen derived from cccDNA. And we'll touch on that. It's also a population where placebo may be possible. So we'll talk through some of those issues as we get into some of the regimens. Now, what I did is try to base this on the FDA guidance that was finalized in April 2022. They essentially say that current therapies are safe, well tolerated. A key element as we think about things that we might try to do to kick the immune system into gear. They also talk about the idea that sustained viral suppression is linked to better liver histology and better outcomes, including decreased risk liver failure and cancer. Also important. And here they outline that S antigen loss is the best predictor of clinical outcomes, really highlighting the emphasis on this particular parameter. I'll come back to that point when we talk about some of their other characteristics. The other thing I'll mention, I won't go through the definition of functional cure. This group is certainly well-versed in this. I wanted to think a bit more about this idea of persistent hepatitis B S antigen, so that continues to be found in the blood, presumably from integrated hepatitis B DNA, but no DNA is detected in the blood. So this is another alternative definition of cure. And the question I want to think about is whether or not this is sufficient to change the outcome of patients. Will there be an ongoing risk of clonal expansion of hepatocytes and malignant transformation in the future if we don't address this issue of integrated DNA? And in fact, in the functional recovery we see spontaneously, clearly there's not transcription of integrated DNA. So this is the FDA guidance on chronic suppressive therapy. Quite a disappointment to many, given that the addition of a CAM to entecavir in treatment-naive e-antigen-positive patients led to a more profound and rapid suppression of HBV DNA. Yet this guidance says that for a superiority trial, it is not clear what the appropriate endpoint is, and it's unclear that more rapid or more potent or deeper suppression leads to clinical benefit. Now, I'll push back a bit because we have plenty of studies that show replication, which clearly occurs on nukes, is bad in terms of prognosis. Yet the endpoint of HCC or clinical outcomes would take decades. They also then say that S antigen clearance may be considered. Sounds a lot like finite therapy, essentially making this a difficult pathway. I wanted to come back to this point on a paper recently published by my colleagues at Hopkins, Ashwin Balagopal and Chloe Teo. And what they did is looked at liver biopsies obtained from people with HIV and hepatitis B. They had stable HIV. We can talk about whether or not there was immune recovery. And they looked to see what the source of the S antigen was based on single cell hepatocyte work with microdissection and primers that they developed. What they essentially noted was that if the primary source, which is depicted by this line on the middle figure, if it's below that line, the hollow circles, the primary source is cccDNA. Those patients actually had a S antigen decline when treated with nukes for a period of time. If the source was more likely or greater predominantly from integrated DNA, the S antigen didn't budge, as you might expect. The other thing that I think is important is that long nuke therapy did lead to a decrease in the amount of transcriptional silencing. So you saw that more hepatocytes were cleared. So in the liver, less hepatocytes were infected, going from 99% in EH-positive patients to a much lower number. And we saw transcriptionally silencing with nukes. Now, if nukes are a lousy antiviral therapy in terms of full suppression, perhaps we can do better. So this is the guidance on finite therapy. A couple of key points. They do offer this S antigen positive, DNA negative option. I already raised some concerns I have about that endpoint. I won't go into it. But they endorse S antigen loss 6 months after and stopping all therapy. I'm going to come back to that as well. And you can see that we don't achieve this very often, even when we deploy interferon and tenofovir. So what about cure with direct-acting antivirals? So if we think about where the S antigen is coming from, these approaches are more likely to be effective in people who have primarily cccDNA-derived S antigen, so younger E antigen positive. Now, I recognize that's not absolute, but in general, those people have less integration. I've listed some of the drugs. I won't get into them all. For example, I won't touch on gene editing, but certainly the promise of gene editing for hepatitis B is great. The risk and hurdles that we need to cover to get there are also great. I think the good news for viral hepatitis B is that other disease states, which are imminently more life-threatening, are pushing the boundaries forward with gene editing. And I anticipate we'll be able to borrow that technology and those safety advances and adapt them to this viral infection. Now, the restoration of immune response is also important, because I want to get to the point, is there a population where we don't need to kick the immune system and increase the potential risk of therapy? Might there be a group that could be cured with antivirals, and if so, how long would that actually take? I didn't stress this, but with the nukes, they've done some modeling with a group in Los Alamos, about 130 years to eliminate hepatitis B from hepatocytes in the liver. Obviously, that's not a time span that works for drug development or for the patient's life expectancy. So I'm going to touch on a couple of things that I think are worth highlighting. The first is bulevirtide, which we know is safe and tolerable. And in the presentation by Heiner Wiedemeyer at EASL in London just this past summer, there was the notation that about 40% of patients with this, obviously, co-infection with D were not on nukes. And we did see a modest decline at the higher dose in HBV DNA. So this idea that entry inhibition didn't lower the S antigen in these patients ignores the idea that it may very well be a potent antiviral or at least contribute to reinfection of hepatocytes. Now, I'll also touch on capsid assembly modulators. I touched on the one that was tested with VBR, tested with entecavir. But these are potent antivirals, and this is, for demonstration purposes, the Alagos antiviral. And we talk a lot about these two mechanisms. I think what's interesting and what's worth thinking about is we talk a lot about this secondary mechanism of blocking the replenishment of cccDNA. Is that really necessary, or will that really occur over time? I think it is certainly important. What we also want to do is accelerate the clearance of hepatocytes. We want to cure hepatocytes. And if we can do that with a nuke, can we do that more frequently with better inhibition of the viral life cycle over time, kicking into this secondary pathway as well? Now, I'll touch briefly on translation inhibitors. And again, I won't touch on all of these. I really don't have a lot of time left on my timer to go through this. But I think there's some important points. This is the Arbutus 729 siRNA. And what we see here is two issues. One, I want to highlight that this study that was presented demonstrates an increase in HPV-specific T-cell activation and proliferation and a decrease in immune exhaustion, at least in CD8 cells. But I also want to highlight that in a handful of patients, well, 2 handfuls to be precise, there was patients who stopped both the siRNA and a nuke. And what's going to be reported in the coming week is that these individuals all still have a DNA level less than 1,000, and none have restarted a nuke for their hepatitis B, suggesting durable changes in that life cycle of the virus. I would love to look in the liver and understand what actually happened. Did we cure hepatocytes? Where is the DNA coming from? There's obviously still active replication. Now, how will we combine this? Well, there's now been a couple of studies, and I'm highlighting at least the press release for the VBR 729 plus nuke study, which in 65 patients did not demonstrate an additional benefit of a capsid with respect to S antigen decline, as well as the study REEF-1 that you're all quite familiar with, demonstrated that adding a capsid to an siRNA was not particularly effective. I want to think for a minute why that might be. And one thing is that the capsid inhibitors block encapsulation of HBV RNA. There was an hypothesis that meant you were depleting the mini chromosome, but in reality, what's probably happening is it's backing up in the cell, and you've got a lot of RNA around that wouldn't ordinarily be there that's eventually being cleared. Might that actually interfere with the mechanism of action of siRNAs that are targeting RNA? Now, that is purely speculative, but there may be an issue with respect to sequencing. I'll touch just a bit on the antisense oligonucleotide targeting translation. Certainly a very important intervention. And I think one of the most intriguing ideas is that it's this combination of the DNA RNA hybrid complex that leads to this activation of pathogen recognition receptors, in particular in the studies presented at EASL TLR8. Now, this highlights the potential both to block viral production of proteins as well as stimulate the immune system in a way that's perhaps getting an antiviral mixed with a immunologic. And then the final antiviral I want to touch on is the monoclonal antibody. And there's an interesting poster presentation that will occur. This just shows the S antigen decline. But one of the potential mechanisms of action depicted in the figure to the left is entry inhibition. And in poster 1187 that will be presented, there's a discussion about a reduction in HBV DNA, again highlighting that entry inhibition, if that's how that's happening, and I don't know that to be true, might be an important factor to consider, particularly in replenishment of infected hepatocytes. So I'll move to get through the immune system relatively quickly. And here, I think that when we talk about ways to stimulate the immune system, and in the HIV world, they used to talk about a kick and kill approach, which essentially involves viral latency. And it's not quite that same approach here. We're not trying to resolve latency, but we are trying to kick the immune system. And there's a couple things that I think are important to consider. One is this mechanism is absolutely critical with respect to integrated DNA. I don't see how we would use antivirals to remove integrated DNA infected hepatocytes. Now, there are a lot of different strategies to pursue this, and I won't touch on those, but just a couple. I do want to touch on the recombinant interferon redux. What you see to the right is a 1976 New England Journal of Medicine paper with human leukocyte interferon looking at Dane particle-associated polymerase activity, S antigen levels, and core antigen. This was 3 patients. So this is but in a sense, that figure looks a lot like some of those we're seeing today at upcoming meetings, obviously different markers. Interferon is a unique and interesting drug given its potential mechanism of action that I won't get into, both with respect to antiviral effect, its potential effect on cccDNA, and as well on immune-mediated response. So interferon, alive and well, approaching 50 years of human trials for hepatitis B. Now, I wanted to combine the idea of therapeutic vaccine and anti-PD-1, anti-PD-L1 into a single slide. So I selected the study that you see here with the chimpanzee adenoviral vector, which encodes inactivated Pol C and the entire S region, and the sequencing of therapeutic vaccine plus low-dose nivolumab. Now, I'll comment that I'm not entirely sure the notion of low-dose checkpoint inhibition for viral infections is valid. When we tested nivolumab, back before it was nivolumab for hepatitis C, we did see a patient cured and another with a large response, but it was at the highest dose we tested in a single dose. And this idea that infections have a different threshold than a cancer, I'm not so sure that makes biologic sense. So we have to think about what low dose really means. So to summarize a couple of thoughts on a few slides, combination antiviral therapy targeting really the elimination of transcriptionally active cccDNA. What's the right population? Treatment naive, e antigen positive, and maybe we can avoid the risk of a kick modulation and allow the so-called restoration of the immune system, or perhaps with some drugs like Bepi, this innate response. Now, what about sequencing? Well, I think the CAM plus siRNA studies tell us that we probably don't need to do that experiment again. It doesn't appear to work. But what if we knock the proteins down? And I'll take that 729 study where you've got people off therapy with still some viral replication. What if we then maximized antivirals after we knock down S antigen with RNAi, and then we treat it for a period of time to see if we could eliminate the transcriptionally active cccDNA? What's the half-life? How long does that take? I have no idea. But I know that we're not potently suppressing viral replication with nukes, and probably not nukes plus VBR. It probably needs a more potent drug, some of which are coming, and perhaps entry inhibition. I don't want to forget that as we focus on Delta. So what about combination therapy to eliminate both integrated and active cccDNA? Here, we've got a population of patients. We know who they are, and there's many of those patients. And what if in this case, we looked at a sequence where we did sort of the same thing. We knocked down antigen production, but then used immune-targeted therapy in conjunction with antivirals. Now, these experiments are being done. I bold interferon because as much as we hate it, it is a drug we know. And keep in mind that the longer you take it, the worse it is. And if we could limit the course of therapy to, say, 3 months or even 6 months, it is far more tolerable for human beings to take interferon. I also don't think we can cut the dose down. I think it has to be a standard dose. A couple things I didn't touch on, like CAR T cells or cellular therapy, very intriguing. And I will say there is a push, fascinating studies on CAR T for lupus and other infections. And the last point I want to make about combination therapies is ethical consideration for research. This was a paper published by Jeremy Sugarman at Johns Hopkins, who does a lot of work on HIV cure. They have a lot of thinking about community engagement. Now, I went through his table here where he talks about that there is a risk with stopping therapy. And he said not applicable. Well, we know that's applicable. When you stop therapy, sometimes people flare. So that's an important consideration. I crossed that out and said to comment. I've got to talk to Jeremy when I get back to Hopkins about this. And then the other one about stigma. I think stigma is incredibly common and absolutely impacts the presentation of patients. And then the last one is a need to engage patient community in cure research, particularly as we think about things like checkpoint inhibitors. So to summarize, I think that there is growing evidence that antiviral therapy can target transcriptionally active cccDNA. Will more potent replication help? How much integrated DNA is too much? And what if we could quantify that with a blood test and say, you know what, this patient has a lot of integrated DNA-derived S antigen. We need to think about this therapy, precision medicine. Immunomodulator therapies will likely accelerate cure for all patients. So I'm not distinguishing these, that you wouldn't use these, but I think it will be particularly essential if we're trying to eliminate this integrated. The drugs and the strategy sequence will matter. I don't have the right answer. And finally, I think we do need more community engagement to calibrate the risk-reward for some clinical trials and some drugs we may approach with. So I'll stop there. Thank you for your attention.